Good morning, good afternoon, and good evening to some of you. We are so sorry about the late start. It is kind of like a Monday, but for some of us, and we're, are getting used to this new technology, GoToMeeting, and so apologies for our tardiness. But I do want to thank you all for coming. I know that for some of you, it's the beginning of your week, and for others, it's the early start. And so you have a lot of options and a lot of choices. So thank you. And thanks also to the Interagency Working Group, and particularly the Research and Data Sub-Working Group that had the vision and commitment to encourage this virtual conference, and to my colleagues at IPAS, particularly Megan Perkins and Bill Powell, who have dedicated their time and energy to bring us all together. And of course, to my panelists, who you are going to hear more about soon. I also want to thank all of you for coming and sharing your time with us. You have so many options and maybe even a little bit of webinar fatigue. And so we appreciate your interest in this work. I'm Tamara Fetters. I'm a senior researcher at IPAS, and IPAS has been a proud member of the IWEG since its inception and was a founding member of the Safe Abortion Care Sub-Working Group. During my career as a researcher, I've had the privilege to work with many of you, and some of you not yet, always working to advance reproductive health and rights, and in development settings particularly, and now as the co-leader of IPAS's research and programmatic efforts in humanitarian settings. I'm a little bit biased, but to me, using our research findings, generating evidence that is practical and useful to others is the ultimate challenge in our field. While I know that not all science is innovative, innovation has really never seemed so important as it has this year. The presenters you're going to hear from today will be presenting on their interventions and tools used in Somalia, Afghanistan, and South Sudan, places where there was no other way to be effective without innovation. And now that so many more of us are facing these same challenges, that work seems even more important to me. As we grapple with global challenges around social justice, fragility, isolation, connection, and shortages. The panelists today have a lot of things to recommend to you from their own experience. I hope that you will enjoy and learn from their experiences, their challenges, and their creativity as I have done in getting to know them. The webinar we're presenting today is a little bit different because it's not directly in line with one of the IWEG sub-working groups, and that is really what I find most interesting about it. We decided to call it Reproductive Health Innovations in Humanitarian Settings, Experiences in Service Delivery, Data Collection, and Supporting Staff. The panelists are going to describe their innovative work pre-pandemic as they were forced to adapt interventions to the unique circumstances of the remote and difficult humanitarian settings where they work. Several of them will also share their lessons about how they adapted during the COVID pandemic. And if they don't, I hope you'll be sure to ask them about it during the Q&A session. They'll present on their use of technology solutions to improve psychosocial support for humanitarian staff, monitoring and reporting using a call center in South Sudan, and a mobile app for improving maternal delivery and the skills of health workers during newborn emergencies. So you are going to be muted during these presentations, but we encourage you to submit your thoughts and your questions through the chat box at any time. You may also send comments or additional resources, and you will see under the handout section, there are already some resources listed there from one of our panelists. We will have a question and answer session at the end, but please don't wait until that time if you have thoughts and comments during the time, and we'll be collating them throughout the webinar and the panels and reading those back to the panelists at the end. You can present a question for all of our panelists or for one particular one. So I'm going to introduce you to our first panelist, and that is Lauren Smith. She is the Global Learning and Research Manager at the Maternity Foundation. She's going to be presenting on improving the quality of maternal and newborn care in humanitarian settings, the results of an evaluation of the Safe Delivery app. And I'm particularly excited about this presentation. It's rare that we actually get to see results of an evaluation of a digital tool. And so Lauren's going to be presenting on that work, and then you'll hear Abdikani talking about the implementation and challenges later on in the session. For now, Lauren holds a PhD in health geography from the University of Exeter in the UK. She's responsible for all the monitoring and evaluation efforts, research, and analyzing the usage patterns of the Safe Delivery app. So Lauren, without further ado, please go ahead and start.
Thank you, Tamara. As you already mentioned, I will be giving a brief overview of the work we've done in Puntland, Somalia, working on maternal and newborn care using the Safe Delivery app. I hope everybody can hear okay because there are some problems. If there's a problem, please put it in the chat and I'll try and fix it. So just a quick outline. We'll give a little background. Oh, next slide, sorry. We'll give a little background onto the pilot study before introducing the Safe Delivery app, which was the tool we used in the field. I'll then go into some methods that we used, as well as presenting the results, and summarize with some lessons learned. Next slide, please. So in 2018, as I'm sure many of you are aware, the Newborn Health and Humanitarian Settings Field Guide was published. As always with new guidelines, there's discussion around disseminating guidelines and how to reach healthcare workers who need the updated information. The Safe Delivery app in this instance was identified as a potential tool for doing so. With funds from Danida and Save the Children Denmark, we were able to translate and upload the low birth rate module of the guide into the Safe Delivery app, and we have a specific Somali language version for this. To understand the feasibility and effectiveness of the Safe Delivery app, in collaboration with Save the Children and approval from the Ministry of Health in Somalia, we implemented the Safe Delivery app into existing programs working on maternal health. The app was rolled out into their programs, and the focus of this study was very much around building the capacity of healthcare workers in newborn care. Next slide, please. So what is the Safe Delivery app? It's a digital tool that provides up-to-date clinical guidelines, as well as a learning platform for users to work their way through. The content of the app is primarily based on World Health Organization guidelines and has been validated by an international panel of experts. The app covers the 7 signal functions of BMOC, as well as additional procedures regarding preventative measures, as well as newborn care. And the focus of the pilot is very much around the newborn care aspect. The app can be freely downloaded from either the Play Store or the App Store. And once it's downloaded, it can be used offline, which is a real advantage here. We're getting guidelines to the end users, and they can use it without an internet connection. As I mentioned, the app can be translated and adapted easily. So we have various versions of the app. We have some global versions, and we also have some versions specific for African countries, as well as countries in Southeast Asia. These are both translated in terms of the language, but also adapted to national guidelines. But rather than me telling you more about the app, I thought you could watch a quick video, which is about a minute long. So if we can play the video now. I think it may have cut out a little quick, but that's okay. We can move to the next slide if possible. Fantastic. Next one, sorry. Fantastic. So that was a quick overview, and if you have any more questions, obviously you can reach out afterwards. But just to update, the app now has 12 clinical modules. As I mentioned, it covers the BMOC signal functions as well as additional modules. We recently launched the normal labour and birth module, and particularly in the current climate with COVID-19, we've added a temporary COVID-19 module, which was developed with Royal Global Health and ICM, and this advises and guides the healthcare workers how to deal with COVID-19 during and after pregnancy and delivery. Next slide, please. So what do we see in Somalia? Before I jump into the study itself, I'll just give an overview of usage in Somalia. So we can see there's around 1,600 downloads in Somalia, and of those, around 650 have told us that they are in Somalia, and they've been online. Obviously, they can use the app offline, but we only collect data when they go online. 97% of these, which is a very high number, have used one of the features that you'll have seen in the videos, so the action cards, procedures, or videos, 1 to 5 times. And internally at Maternity Foundation, we have a definition for engaged users, and these are users who use the app in a meaningful way, so they can actually learn from the app. And here we see in Somalia that there's a 70% engagement rate, which is really good and it's very high compared to our global average of 52%. So this gives an indication that users are using the app in Somalia and that the program is rolled out as intended. We also know that the users in Somalia spend around 3 minutes per visit to the app, which gives them enough time to watch the video chapters or review information in some of the other features. And looking at the profile of users, we see that the users in Somalia are primarily midwives, working in primary health facilities with 1 to 5 years of experience. And then just jumping quickly to the My Learning, the e-learning platform, we see there are almost 220 My Learners. 6 of these are classified experts. So this means 6 users in Somalia have worked through all of the modules and completed all of the 3 levels. And then 1 person in Somalia is actually a safe delivery champion, which means not only have they done that, but they've then sat down and taken a roughly 2-hour exam within the application and have passed the exam and now been classified a safe delivery champion, where they get a certificate to say that they know everything they should according to the act. So we can jump to the next slide. And the next one actually. So now I'll go into the study itself. So we did a pre and post implementation study in Puntland, Somalia, and within this we looked at 2 regions, Kakar and Udog. The healthcare workers that were enrolled in the study work in primary and secondary facilities, and it was a 10-month implementation study. It started around January 2019 and ended October 2019. What we did was send somebody from Denmark to Somalia who did an on-the-ground training of 5 days of GOT training. This was with Save the Children staff as well as Ministry of Health staff. And the training involved training them around the app itself, but also suggesting and guiding how the application could be integrated into the existing BMOC curriculum. So following this, we enrolled 38 healthcare workers across the 2 regions, and the healthcare workers received a 1-week-long BMOC refresher training. So this was the combination of the BMOC as well as using the Safe Delivery app. Following this, the healthcare workers were advised to use the application as a job aid and a reference tool, both by themselves at the facility, but also when they had monthly supervision. So across the 10 months, when possible without any security risks or anything, there was a supervision that occurred. So Save the Children staff would go out and supervise and really strengthen and build the capacity of the healthcare workers, particularly on the skill level that they had. So if we can jump to the next slide. Within the study, we had 3 research outcomes. So we were very interested in self-reported confidence of the health workers, the knowledge, and also the skill. So the confidence was measured on a self-reported questionnaire based on the Likert scale from 1 to 5. So healthcare workers could report whether they felt panicked or through to confident. The knowledge survey is a standardized survey that we have, and it consists of 33 questions covering all aspects of the application and the modules within. The idea of the knowledge survey is to assess clinical knowledge change over time. So we give both the confidence and knowledge at baseline, midterm, and endline. And then the skills test. This is probably the strongest proxy indicator for quality of care because it incorporates both the theoretical knowledge but also the practical skill, and that's what they're doing every day. This was assessed using objective structured clinical examinations, in other words, OSCEs, and these are simulated drills. So the midwives are given a scenario and we work through these with those, and then they get marked according to the speed, precision of what they're doing. And we did these for 3 measures for newborn resuscitation, newborn management, and low birth rate. And because they're quite time consuming, these were just done at baseline and endline. Next slide, please. So if we look at the confidence first, you'll see it's relatively stable across all the modules and at the average. So we saw at baseline, which is the orange bar, that the healthcare workers felt that they were coping, which is represented by a 4 on the bar. We actually see this remain stable throughout, and at endline, they're also feeling that they're coping. When we move to the next slides, you'll see that the confidence actually seemed relative. Oh, sorry, we're not moving yet. When we do move, you'll see that the confidence level appears to be relatively high compared to their knowledge and skill level. So this needs further investigation, but one explanation could be that the health workers felt quite confident, and then as they learned more about the procedures, they didn't change their responses because they were already quite high. As I've mentioned, this will need further investigation. We can see that the confidence increased the most in the middle for vacuum extraction, and we actually saw the self-reported confidence move up a whole level. So they, instead of feeling scared, which is represented by number 2, they no longer feel scared. So that's quite a nice thing that we can see that happening over the course of the project. However, we do see that the confidence fell across 5 modules. So it fell in manual vacuum aspiration, active management of 3rd stage labour, retained placenta, maternal sepsis, and kangaroo motherhood care. And again, through qualitative data, which we will not be presenting today, we hope in the future we can dig into some of these results and find out why this is happening. Next slide, please. So the knowledge results were much more varied than what we saw in the confidence. We saw that overall, from baseline to endline, that there was a 14% increase in knowledge. And there was actually a bigger increase from baseline to midterm, and that was a significant change over time. Although we would have liked to have seen the knowledge increase continuously throughout the project, it does actually follow a general learning curve that we do see in other programs, where participants' knowledge increase closer to the training date, and then as time goes on, it does drop off. So we would have liked to have seen it continuously increase. However, it is reassuring that it doesn't drop off below the baseline. Again, this is something we will investigate going forward, but it's good to see that pattern and that general trend that we see elsewhere. We can see, according to the graph, that prolonged labour and neonatal resuscitation were not their strongest points, particularly at baseline and endline. They peaked for those modules, at least in midterm, so again, something to further look at. And we actually saw throughout the course of the 10 months, the knowledge for low birth rate increased at each time point, which is really when we move to the skill level. So if we can jump to the next page. Super, thank you. So the skill level, as I mentioned before, this is the strongest proxy indicator for quality of care, and this is actually where we saw the stronger results. This could also be because they had the mentorship, and the focus was very much around the skill. The mentorship visits were focused on the skill rather than the theoretical. We did it for the three modules, as I mentioned: neonatal resuscitation, newborn management, and low birth weight. And across all of these, we saw a significant increase in the level of knowledge and skill from baseline to endline. We can see at baseline that the low birth weight OSCE was the highest score on OSCE, so it scored just over 50%. This was higher than neonatal resuscitation, 13 percentage points higher, in fact, and 21 percentage points higher than newborn management. And at endline, we continue to see that the low birth weight module is higher than the others. However, the difference now is less. So it really shows that through using the app and the mentorship that we can bring some of the other skills up to a similar level. So now we're only seeing an 8 and 12 percentage point difference respectively from neonatal resuscitation, newborn management compared with the low birth weight. So we are seeing that increase. And then although the newborn management scored the lowest overall for the OSCEs at 71%, it was actually the OSCE that we saw the greatest improvement in. So we saw a 121% increase in the level of the newborn management skill assessment through the OSCE. And this again is an interesting finding, because when we compare it with the knowledge result that we just saw, we see that the knowledge for that module is quite low, yet their skill level has really increased. So I think there's something very much around theoretical knowledge versus practical knowledge. And obviously they're doing these procedures regularly, they're learning about them through the mentorship and so on. So that's the strongest proxy indicator, and hopefully we'll be able to dig in more, and I'm sure when Abdul Hamid talk through a little bit more about these visits. And then the smallest skill change that we saw was the low birth weight, but as I mentioned, the baseline was already higher. It's just really reassuring to see that by endline, they're all at a similar level, which is what we were hoping to do. And then if we just pop to the last slide. Super. So obviously I've just gone through this very quickly. If you have any questions, please pop them in the chat or reach out afterwards. But just some lessons learned from this small study that we did. We feel that combining training, supportive supervision, and the application do have a positive outcome on both knowledge and skill, particularly the skill area. The supervision, as I've said, and the project is very much around building the capacity of the midwives and focusing on that skill level. So the pilot has proved successful in this. However, we could begin to think how we can improve the knowledge level to correspond to the skill level. The pilot for us suggests that integrating a digital health tool into existing programs, it can help bridge the gap between training and access to information. And we think this small pilot has shown this, and hopefully if we're able to scale up or roll out further, we'll be able to look at this further and hopefully get some stronger results and more results from our participants. And finally, we feel that the learning from this experience will hopefully assist in future dialogues around using digital tools and training methodology in humanitarian settings, and how we as a community can provide the most efficient and effective trainings going forward. And then the last slide is just a thank you. So thank you very much for listening, and if you have any questions, please do reach out.
And thank you, Lauren. I mean, it's always a pleasure to see results of our work being evaluated. Oftentimes, it is difficult enough to introduce these interventions and far more difficult to produce evidence that they are effective, and also to look at what works and what doesn't work. For our next presenter, I would like to introduce Dr. Lucia Bertondini. She is a Gestalt, I practiced her name, that's why she's smiling at me, Gestalt psychotherapist and senior lecturer at the University of East London. Lucia has been working for the past 15 years in the field of humanitarian psychosocial intervention, mainly in countries in war and post-conflict, such as Afghanistan, Angola, and some areas of India. At the University of East London, she is a course leader of a distance learning Master's in Science program on humanitarian intervention. And again, I'm very pleased that she's sharing this work and also the results of an evaluation. She's going to be presenting on psychosocial support for humanitarian staff with Marie Stopes International in Afghanistan.
Thank you very much, Tom. And yes, so what I'm going to present is a study that, an intervention that ran between 2017 and 2019 in Afghanistan in collaboration with Maristops International Afghanistan and also with the University of Herat, and in particular with Mr. Ali Kaveh, that has been collaborated with myself and other colleagues for a number of years. Next slide, sorry. Very briefly, so Tamas already said and introduced myself, but just to say that, just to explain the context where this project started. I have collaborated with the University of Iraq since 2010 with a number of projects, and one of them was to co-construct an intercultural training in counseling that has been approved by the Afghan Ministry of Higher Education in 2015. So now the University of Iraq runs this model of intercultural training in counseling as a BA in the Department of Psychology of their university. And basically, this model of intercultural training was the base model we referred to when we then did the psychosocial intervention that I'm going to present today. And I think among the documents that have been already shared, there are a couple of articles that we publish over the years with the University of Herat that basically explain more in details, because I won't have time to do that today, how we really tackle intercultural aspects of this training, including some challenges. As Tam said, I'm now senior lecturer at the University of East London, and I lead a distance learning MSc Humanitarian Intervention, where we focus particularly on psychosocial intervention and the psychological aspects of humanitarian intervention. Next slide, please. So as I said, this is a collaborative project between UEL, the University of East London, Maristops International, and in particular Maristops International Afghanistan, and the University of Herat. Next slide. From research in the psychosocial area of humanitarian intervention, is very clear over the past 10-15 years that supporting aid workers' mental health is fundamental and crucial to ensure efficacy and sustainability of all psychosocial interventions. And obviously, psychological, psychosocial intervention are crucial for beneficiaries, but aid workers are equally often exposed directly to a number of challenges and potentially dangerous situations, especially in volatile contexts like countries in Afghanistan, for a number of problems and issues that make them then a high risk of a number of psychological issues. So make sure that we can provide support and psychological support to the aid workers is a very important aspect, and is probably one of the areas where I've been particularly passionate about. One of the trainees that trained with us at the University of Herat happened to then start to work as a counselor for Maristops International Afghanistan, and I was in touch with them. So over the time, that's why we got in touch with Maristops International Afghanistan, and we started to dialogue together and identify the need to provide some support for the staff of that branch of Maristops International. So the project was created in collaboration among all of us, and really intended to improve the well-being of the Afghanistan providers of Maristops International. And we then used as a model the counseling course that we developed with the University of Herat. Next slide, please. So just to give you a sense of chronologically what happened over these over the time for this project. We started in November 2017. I think that this is one of these slides that were, well, animated with is supposed to appear one way. Yes. So in November 2017, we, as a first step, and I think you need to click, yes, we did a survey with 140 members of staff of Marie Stopes International using the Afghan symptoms checklist. I'm going to talk about that in the next slide. It's a tool that has been developed by Miller and other colleagues in 2012, and I particularly find that very useful because it's one of the few probably culturally sensitive tool to measure a stressor, and it has been developed in collaboration with universities in Afghanistan. So it's inclusive of some items that describes dimensions of stress or well-being using specific terminology and concept that are typical of that culture, and so are not the classical reference that is more related to the Western culture and not necessarily always apply or is applicable or recognizable in other cultures. So we collected those data to have a general sense of the level of stress of the staff. And then in January 2018, based on that, I went to Kabul, and in collaboration with Ali Kaveh from the University of Herat, we carried out 4 focus groups with different representatives from different cities of Afghanistan, of Marie Stopes. And basically the aim of the focus groups was to check with the staff what would they think would be beneficial for them in terms of psychosocial support and make them more able to deal with their daily challenges in their life and in their job. And so based on the results that again I'm going to discuss later in a specific slides, then in May 2018 we carried out in Kabul 5-day training course on psychosocial counseling skills that really was tailored on the different items that were identified by the focus groups. And the specific aspect of counseling skills was, as I said, referred to the model that we developed together with the University of Herat previously. And finally, between January and June 2019, what we did was to carry out with a subgroup of the team that was trained in May, Skype supervision online. Now we call that supervision, I guess it could be called a reflective practice group. It was a monthly meeting, and again, I'm going to give detail in a second, where the team were meeting online, and Ali Kaveh and myself were facilitating the process. And we are going to see later what emerged from that. Next slide, please. So just to give a bit more detail for each one of these steps, in November 2017, we collected these 140 participant data about the questionnaire. The questionnaire was collected in provinces of Kabul, Herat, Balkh, and Jowzjan, and the participants were managers, doctors, midwives, and administrators, with a sample composed of 85 females and 55 males. Now, in terms of the results, most of the items were non-significant, and in general the result was quite showing a quite contained level of stress, with the exception of the item that was related to dealing with upsetting memories, and there was a significant discrepancy in gender, so women were disclosing a higher level of stress than men. Next slide, please. And as I said, after that, then there was a 2 days collecting data through focus groups in Kabul, where the staff basically identified core issues that they would like to be covered during the next training in May. One was recognizing mental health signals in self and others, so how to recognize signals that about well-being or a high level of stress in themselves, but also in all the clients they have been working with. And of course, there were a number of situations where they were reporting during the focus group that they had to deal with either individuals or families that were going through a quite high level of trauma, and they felt that they didn't have the capacity or the competence to really deal with that aspect. That was at the same time fundamental in the work that they were doing. Managing stress, and then they were also asking for some basic psychosocial counseling skills in response to trauma, again to implement their capacity to deal with populations affected by trauma. Next slide, please. So when we then carry out the training in May 2018, that was 5 days again in Kabul, full immersion, meaning that we were really spending the whole day from 8 a.m. to quite late in the evening together with a number of activities. We had in total 17 participants, and it was a selected group where there were the managers of the different branches in Afghanistan and some of the counselors, again working in different provinces for Maristops. And we then, as they required, we focused some input on mental health issues, psychosocial counseling skills, working with trauma, and also we did some training for trainers across the days in facilitating group processing. So we try to implement and do through experiential activities in turns for them the experience to really moderate and facilitate group process, so that then could be considered first training in making sure that this could be an activity that Maristops Afghanistan could keep as a part of the system, as a sustainable way to diffuse the stress and the level of stress of the staff. And the training was a combination between theoretical input, but there was a lot of experiential activities, and this was based on the counseling training that we developed together. So we used a lot of art therapy, play therapy. Gestalt is very facilitative of this kind of creative ways, and again, this from previous experience from previous projects done with Herat turned out to be a very crucial way, because there are a lot of topics that really in, for example, the Afghan culture cannot really be disclosed directly and explicitly. And yet there are many ways to work therapeutically, working with metaphors, with art, with stones or puppets or poems that are very close to the culture, and so can become a very natural way to express themselves, and at the same time staying in the process and in this client experience, you can develop therapeutic processes protecting certain the difficulty in disclosing directly certain topics. At the conclusion of this training, it emerged the need to continue having a sort of space where the group could be supported, but also have a chance to share, for example, difficult cases or challenges that they were facing. And so we decided to move on online, because also I'm based in UK, but also they were based in different areas of Afghanistan. So using an online platform to keep doing this. Next slide, please. So the last part of this project that ran between January and June 2019 was to do Skype supervision once a month, and each session lasted 2 hours and included guidance on how to support clients suffering from severe trauma, domestic violence, quite a lot of topics that were actually quite common in the clients and patients of Maristops. But also there was a lot of attention and a lot of support in terms of self-care for the practitioners themselves. And I guess a lot of the climate and the outcome of the processes that was part of these supervision sessions that were very much based on a humanistic framework, so person-centered, Gestalt, humanistic, was really about supporting the experience of the individuals and creating a climate that was of inclusivity and peer support. At the end of these 6 months, the supervisees were asked to fill in again the Afghan symptom checklist and were interviewed individually via Skype using semi-structured interviews just to evaluate this experience. Next slide.
Lucia, I'm going to have to ask you to go quickly through the last slides.
Yeah. So the results suggest that in general we have a clear decrease in certain items related to the stress, and although obviously the participant group was very small, so statistically this is really just an indication, but more relevant was probably the qualitative interview, where the responses of the participants indicated an increase in their confidence in their skills and ability to provide high quality services. Next slide, please. So it seems very important and doable sustain reflective group practice using an online platform. We did use Skype, more recently we tried Zoom, Microsoft Teams. They seem to be all good, particularly Microsoft Teams, I think, is the one that we have been using more recently. And now the counseling service in Afghanistan has been implemented, and they now carry out counseling service in female prisons via phone in different ways. Next slide, please. We do know that it's very important to offer psychosocial support and counseling support to the staff. And I think we can go to the next slide just to offering this reflective practice space for staff seems to confirm what has been already highlighted by precedent studies and literatures, and so we are actually trying to expand these in other contexts, in other countries, with Marie Stopes and with other NGOs as well. The final slide. And then, so what we do at the moment with UL, with our program MSc Humanitarian Intervention, is that we open an online portal dedicated to the support of mental health. Support of mental health of healthcare practitioners and humanitarian aid workers, with various resources, including also online webinars and regular reflective practice groups, where they are facilitated by a number of different people to implement these aspects of the psychosocial support of the staff. I finished. Thank you very much.
Thank you so much, Lucia. That was so fascinating to me. I'm going to go quickly to the next presenter. I think that the really interesting part of these panelists all together is that they're all addressing very different challenges. And now we're going to talk about a different challenge. Job Malapo is a humanitarian management professional with over 10 years of experience in supply chain, project oversight, and operational expertise. He has provided regional expertise to NGOs in Ethiopia, Zambia, Liberia, and South Sudan. And he's currently the country director for the Global Health Supply Chain Project in South Sudan. He holds an MBA in Operations and Supply Chains and a Bachelor of Commerce in Logistics and Transport. He's going to talk to us about utilizing a call center in South Sudan to address commodities and supplies. Thanks, Job.
Thank you, Tam, for the introductions. Let me start by saying that what I'm going to share is not from the research perspective. That is one of those innovations that you kind of come up with when you hit the ground and you want to implement, and you realize that something has to be done to make us be efficient in what we're going to do on the project. And so what I'm going to present is basically utilizing an integrated call center approach in South Sudan. Can you go to the next slide, please? So just walk you through the background and then why we came up with what we came up with, and what it is that we came up with in the light of system design, information flow, and then the platform itself. We will look at a bit of the benefits that we have seen so far, and how that the data that we derived from there has been able to help stakeholders kind of make some decisions, and some of the ways we drive this forward. Next slide, please. So let me again just state the background of the context in which we work in. And I know that this is not only unique to South Sudan, but to a number of countries across the globe. But most importantly, South Sudan, as we all know, is probably the newest country in the world. And that comes with a lot of challenges in terms of infrastructure, human resource, safety and security challenges, regional travel limitations, erratic and in most cases unpredictable population movements. And so that makes such a fragile environment very complex to especially try to know what is happening in health facilities. But that is coupled with supply chain challenges, usually parallel systems that are in most cases donor funded, and multiple distributions or deliveries to health facilities that might not be visible through the supply chain, because logistics management functions are usually non-existent or very limited or siloed to the specific agencies that are implementing. So that obscures the data visibility, and then you might not even realize when the reoccurring the commodity stockouts happening. And also a lack of structure and accountability. And so things kind of get lost in the cracks. Next slide, please. So once we hit a scenario like that, we started asking ourselves, how can we possibly implement in such an environment? How do we know what is in the stores for health facilities? How do we know whether distributions have reached there or not? And so that was our cardinal question that we had to ask ourselves. How can we increase data visibility of health commodities at service delivery points in South Sudan? Next slide, please. So the integrated call center kind of became an answer for this type of context that we found ourselves in. And I would like to take a moment here and to say, to appreciate the people and the brains behind this innovation. There are a number of people in the background, and I know that most of them are probably listening to this webinar. And so again, thank you, team, for the work and an opportunity to put this together and be able to share for everybody to see the work that is being carried out in South Sudan. So the call center was built on what already exists, without really shifting a number of things or being able to look for resources that will help implement this innovation. So it basically uses the telephone coupled with online platform for data collection. And this platform includes voice recordings of all the calls that are made to the facilities, and I'll show you that in a second. It has capabilities of outgoing, both outgoing and incoming calls, and it's also able to generate data that is shareable, whether it is downloadable voice recordings or the actual data that is entered, as I'm going to show you. So this went a long way in kind of helping us have that degree of data visibility in as far as facilities talks are concerned. Next slide, please. So what you're seeing in front of you right now is basically how the infrastructure is all built up. So the design, the reach, and the flow. As you can see, again, let me just make sure that this is a little bit clearer to everybody listening. Usually when people think of a call center, they would think of probably handsets and people calling, but this particular one is a little bit unique in that there's no handset. It's all done on the computer, and so you can see those ready pictures on your left, the people sitting and the computers on the next graphic. Then so they make calls from there. All the data has been input into the system, starting with the names of the contacts in the respective facilities. Then the commodities that need to be input and all that. And the system basically requires the network at the central level and the phone system that is able to help call and reach the facilities where the stock managers. On your far right-hand corner of the stock manager, and these stock managers basically are responsible for county health departments. These are just depots where counties stock and distribute health commodities. Some of it are hospitals, some of it are primary healthcare centers, and some smaller units of health facilities called primary healthcare units. And so, as I highlighted initially, once the calls are made, and as I will demonstrate in the next slide, then you can generate reports and you're able to share, you can able to do the data analytics and be able to disseminate for onward decision making. Next slide, please. So what you're seeing right now is what we call the landing page. So when you go into the actual platform of the integrated call center, this is what you see. So you see the integrated call center tool with a round red triangle around it. So that's where the call center agents actually go into and be able to access the platform, be able to access the call, the handset, which is laid over data that they can use to make a call. And then once the calls are made over time, you could, you have a dashboard there that kind of shows you what is happening, and you can see both for administrative purposes, but also for data itself. And then on the far right-hand corner, you can see a help desk just to register the issues that the call center agents encounter in the course of their operations. Next slide, please. So once the call center agent opens or clicks on that first button that you saw on the landing page, this is basically what they are able to see. So it's you can see there's test facility, and so this is where data is all entered from. On the bottom left-hand corner, you can see the arrow there, which kind of shows where the call center agent enters the data. Most of this data is pre-loaded. So this is the name of the commodity, whether it is being used in that facility or not. and then the date has to be input, and the other details of the quantity on hand, and the rest of the details. Next, click please. So once, as the call center agent is entering data, he or she is guided by what happens on top there, like has she completed all the commodities, has she checked all the commodities that are in this particular facility. And so you can see the completed items, pending items, total items in the inventory. So in this case, you can see that green smiling 5, meaning that all the data has been entered. Next, click please. On the far right-hand corner, again, there is a summary of details there, which shows the expiry for 3 months. And if there is any expiry, as you see in the next slide, it definitely shows the call center that there is a stock out, or there is some expiring commodities in this particular facility. Next slide. Thank you. So this window that the call center is able to see basically gives the call center agent all the information that she or he would have entered in during the call that he or she had made to the facility. So that yellow numbers and descriptions there just show almost all of the data that is entered. Next click, please. So as I said, you can see that red there with a cycle on that yellow bottom patch. That would be how a stock out indicates. So immediately the call center agent realizes that there is a stock out in this particular facility, and then there are protocols that are followed to make sure that that is mitigated along the way. Next click, please. So this is the most exciting part of this particular platform, in that it just doesn't provide the data that is entered in that yellow slab at the bottom, but it also provides a voice recording. So that cycle, I'm sure you can see at the bottom of that cycle, there's a small play button there. So that is the recording, and that recording you can download, you can listen over to see if the call center actually entered the data that was provided. So you have the voice recording that you can verify the data with, and the actual data that is entered by keyboard that can also be downloaded, can be, pulled out over a period of time, analyzed, and you come up with some reports. Next slide, please.
Job, I'm going to have to ask you to go very quickly through these last slides, so Abdikani has time. So
thanks, Tam. So the main benefits that we have found with the call center is the early stock out and expiry detection. And this happens when the calls are being made. And as I demonstrated earlier, you could see that there are visible signs that there's a stock out or there's an expiry. Early inventory stockpiling. So as the call center agents are calling, and they're always giving high numbers, or numbers are not changing downwards, then this facility is not getting the stocks out of the facility, and there's likely going to be spoilage, and decisions have to be made. Then you're also identifying stock trends at service delivery points helps to triangulate this data with other data sources like DHIS2 and other data from the supply chain, from individual implementing agencies, just to make sure that the data is triangulated and that there is agreement in the data. Next slide, please. So as I mentioned, the graphic on your right just shows like the monthly inventories that are being collected. You will notice, just next click, please. So you will notice that around November there, those lines actually represent the commodities. As you can see, the blue is combined oral contraceptive, the green is Implanon, and the red is Jadel. And the dots actually show the call center data that was collected upon calling this call center. And you can see that in November, it also detected some spikes, which means that there are some commodities that got into this particular facility. Next slide, please. And over time, what we have seen is that we were able to use the call center data to bring about discussions. Like you will notice that certain facilities have commodities that have been sitting there for a long time. And this brought about conversations, how do we improve consumption, and the issues of youth-friendly services and service provider training came up. Other issues that came up during stakeholder discussions was how do we ensure that we provide stocks that are adequate for particular facilities. And so this went into kit design and dissemination discussions to ensure that there is always access to contraception, but also that there is not overspoiling, there is not overpiling and spoilage. And then it also helped us to be able to realize that there is need for quantification from time to time, and be able to share the data and be able to analyze the consumption through consumption reviews. Next slide, please. Okay, and so, yeah, moving forward, again, like I started, this idea is basically built on what people do in supply chain, but just providing that structure and evidence, and also data that is able to be used over time. And so, you know, like we all know that there are always transport needs, there are always papers that are filled in to make sure that data is collected. There are always people that are doing all these things. There are always phone calls that are done from cell phones and no recordings and no data. But this particular innovation provides that structure to be able to pull all the data together and make sure that there is data visibility at the health facilities, which eventually improves supply chain management. And so I would want to mention also that different countries have different needs. And at the moment, we're using the call center in Mozambique, Haiti, Niger, and Mali and Cameroon. And of course, I can proudly say it started from South Sudan. And there are different needs in these particular countries, which have different contexts. And so the call center is helping us answer those respective needs in each of these particular countries. Next slide, please. And I believe it's the last one, Tam.
Yeah, thank you.
Thank you. So yeah, in case there are any questions beyond this, there's an email address that we put up there, and you can reach us and we'll be able to address those. Thank you.
Thank you, Job. I just want to make sure Abdikhani has his time. So without further ado, Abdikhani Shire is a humanitarian and development professional with over 5 years experience in humanitarian and development programs, particularly in reproductive health. He's currently pursuing his master's degree at Mount Kenyon University with a specialization in epidemiology and biostatistics, while working at Save the Children International in the Somalia country office as reproductive health manager. Abdikhani is going to talk to us about the Safe Delivery app as well in Somalia, but more from the perspective of implementation and use, and showing some of the lessons learned from actually implementing this app on the ground. Thank you, Abdikhani. Please go ahead.
Thank you very much, and good afternoon, good evening, and good morning to all of the attendees around the world. I will be talking about leveraging digital solutions to address clinical training gaps in humanitarian setting. So please, next slide. Next. So we'll be talking about safe delivery app implementation in Puntland, Somalia. And this pilot project has been started in back in 2018 October, and that was ended in 2000 November. The pilot study, though the actual use is still continuing and are integrated in different perspectives. We'll be talking about background and context, description of program and interventions. Our lesson we learned about the safe delivery app and conclusion. Next slide, please. Increasingly, the global burden for maternal and newborn mortality are concentrated in countries affected by humanitarian crisis. And as you are aware that Somalia have been in more than 2 decades of civil war that led Somali health system very weak, that contributed high maternal mortality to about 682 out of 100,000 live births. And that was the recent data that have been launched in 2020 April about Somalia healthy demographic survey. This is the latest data that we have recently launched this year. Again, interpartum or stillbirth 30 over 100 over 1,000, a newborn mortality of 38 over 1,000 live births. While these are improving, we compare to last SHDS conducted back in 2015 and before. Next slide, please. Again, as I mentioned, the Somali Health Demographic Survey found that these outcomes were attributed to low rates of institutional deliveries, of which is around 21%, or with skilled healthcare providers of about 32%. For women seeking delivery at health facilities, they were more likely to seek care at public health facilities compared to private facilities. This remains true even for urban areas. Again, young mothers under 20 years old were more likely to have skilled deliveries attendance at their last birth. Again, prenatal mortality was highest among women aged 30 to 34 of age. Again, 48% of Somali's health facilities report over a normal delivery services, which means the complicated cases are not managed, which again contributes to high maternal and neonatal mortalities and even under 5 mortalities. Next slide, please. The Federal Minister of Health in Somalia established in 2012 and prioritizing development in healthcare workforce clinical education programs proliferated mostly in the private sector. Again, a study conducted in 2017 exploring the training opportunities available for the reproductive health profession in Somalia found a lack of standardization or regulation of these programs from the federal government, which means there was a very fragmented curriculum, again, institutions, and the quality was very low. That contributed low capacity of the health workforce in general in Somalia, particularly in regard to the newborn and deliveries. Next slide, please. The deaths can again, many maternal mortality, prenatal, and newborn death can be prevented with access to trained skill providers. Again, as we mentioned, in Somalia, 22% of the workforce needs are met due to the severe lack of trained professionals. Crucial to support frontline health workers with access to up-to-date clinical guidelines and opportunities to build knowledge and skills. Which we believe that using self-delivery app will be one of the best solutions to support either as a guideline or even as a job training during mentoring and even at pre-service trainings. Next slide, please. When we are talking about humanitarian interventions in Somalia, delivering supplies and equipment alone are not enough, as we believe. But again, the quick theory-based refresher training as well as. In general, humanitarian donors are more likely to fund short in-service refresher training or delivery of supplies. These cannot be shown to be effective at changing practices or improving outcomes. Self-referential research on newborn health in Somalia has found that delivering supplies and equipment without combining service provider training is not enough to change or improve maternal and newborn care outcomes. Again, the lack of quality pre-service training and standardized materials that are specific or context-based are not available, and of these all issues we are trying to improve and have some evidence-based interventions that will eventually improve the quality of service and quality of deliveries or service delivery across Somalia. Next slide, please. Evidence for effectiveness or competence-based maternal newborn health trainings in Somalia. As I said, Save the Children research has shown that investing in quality clinical training using evidence-based curriculums and competence-based learning methods can give providers the necessary knowledge, skills, and competence to improve their maternal newborn healthcare practices. Further, Save the Children research shows that these skills are not only retained at 18 months post-training, but that training participants diffuse knowledge and skill back at their facilities to other providers. So this will Save the Children research or evidence-based related in Somalia are now used globally by the donors, partners, or other implementers, and even the government officials to improve the quality of the trainings provided either in pre-service or in service trainings. Next slide, please. However, barriers to quality competence-based MNH trainings in humanitarian setting are the following: expensive, as we know, the trainings are very expensive, requires extensive organization and planning. Especially these issues are very again challenging in an environment like Somalia with a very weak health system or government system at all. Though now the situation is improving day by day, and as a Save the Children, we believe we are contributing a lot in improving quality of health service across. Again, full competence-based clinical training is recommended for training mid-level providers on providing quality emergency obstetric and newborn care requires immense amount of resources and time that are already rarely available in humanitarian settings such as in Somalia. Yet clinical competent and competent workforce are essential to address the disproportionate pattern of maternal and newborn mortality in this setting as Somalia. Next slide, please. So we believe innovative ways could improve these all challenges and barriers that we have already mentioned. And we found safe delivery app as one of the best innovative way in delivering competence-based trainings, mentoring, and supervision for frontline staff in Somalia. Next slide, please. Uh, as we said, Save the Children Somalia supports over 394 facilities, mainly public facilities, with a committed focus on maternal, newborn, and child health interventions. Also, Save the Children prioritizes capacity building of the government health workers across all categories to provide quality, safe motherhood counseling, obstetric, and newborn care during pregnancy, delivery, and the postpartum period. Save the Children has continued to adapt evidence-based global common approaches in our health programming with aim to improve the lives of Somali children or life of children across the globe. This one global or common approach included sexual reproductive health in newborn or safe newborn life, sorry, and so on. As you can see, and also as Save the Children, we're aiming to scale up our low-cost, high-impact intervention to hard-to-reach areas and to benefit the most deprived children and advocate with the government, donors, communities as they do as they key duty bearers for improving access to affordable health services for the most vulnerable populations, especially children across Somalia. Next slide, please. As you can see, and even made so in the past presentation, this is the implementation area the Safe Delivery App, and there are two regions, Karkar and Mudug, and we were targeting 38 health workers from 15 health facilities from both regions. Next slide, please. Again, we integrated the app with BMOC refresher trainings that were conducted for the midwives. And in this training, the midwives were trained on techniques and practice of helping mothers to deliver babies and giving them advice and support to pregnant women. During the training, we focused, the training was or most presentations were driven from Somali Safe Delivery App and rights protocols that have been translated into Somali language, both of the protocols. Next slide, please. As I said, integration of the SDA of Safe Delivery App to the BMOC training was very crucial, and facilitators were initially introduced to the SDA and how they can use and were requested to install in their smartphones. And then facilitators reviewed BMOC curriculum and inserted to the SDA. Participants also were requested to download the app, and a session were provided in how to navigate the app. And most participants have a smartphone, while those who don't have were sharing with their colleagues. And these were very interesting and very interactive sessions, as the participants were either watching videos as appropriate and interacting with each other. Next slide, please. Also, the SDA was used by the trainer providers. The tool was used as a reference for BMOC training. It's used as a job aid. Again, participants report that primarily use SDA to receive knowledge. 90% of the participants use the self-learning platform or My Learning. In addition, supervisors from both Minister of Health and Save the Children used the app during the on-site supervision visits as a guidance for mentoring and on-job training. and the application used to address the gaps of knowledge, skills by supporting access to guidelines provided, as I said, and as a guideline for supervisors. Next slide, please. As the feedback from the team, both Save the Children and and Ministry of Health, they acknowledge that the app as whole and at Somalia as large as a context where healthcare provision is limited due to the numerous factors that we mentioned, and provision of capacity building opportunities of active professionals challenging and limited. In such context, adapted training methods and innovative providers are essential to cover the gaps. And Safe Deliver App was one of the proven to be relevant tools to support adapted trainings and an important as an important job aid with key health professionals not only apply for facilities when working, but also when reviewing key clinical knowledge with their colleague or on their own. Next slide, please. The nurses and midwives stated that SDA provides them with readily accessible, up-to-date information, including caring for mothers and newborn with complications in their own language and available at their place of employment. They also reported that quiz in my learning motivate them to continue learning, which is we found was the most important motivator or factor that contributed the downloads and the usage you saw in the first presentation across Somalia. Next slide, please. And this lady, one of the doctors in one of the newborn facilities in Puntland, and she found the teaching video was very captivating and interactive and not boring, which has stimulated her learning. That's what have been said by the number of providers that have been benefited or have used the Safe Deliver app. Next slide, please. As a lesson learned, our lesson is learned from implementing Safe Deliver app in Somalia. Save the Children and more teams have reported that frontline program staff, project managers, and clinical supervisors are empowered to support health workers with a specific maternal and newborn health interventions using the Safe Deliver app. Team members commented that the tablet-based SDA is best method to enable continued education for nurses and midwives. Though the availability of tabs for all the health workers is challenging, but as we know that we are in the center of the technology, most of the service providers are using smartphones that they are able to download the app in their own smartphone. Also, adapted training methods and innovative providers are essential to cover the gaps, and the SDA provided SDA Somalia and more tool to improve healthy worker capacity to provide evidence-based maternal and newborn health care through existing material and health programming. And as we said, the Safe Delivery app was not was cost effective because Save the Children with support from more integrated the Safe Delivery app into the existing programs and trainings to improve the curriculums available and the resources available for the trainees. Again, recently it has been agreed and Minister of Health recommended the Ministry of Education to use or to recommend the Safe Delivery app in the pre-service education institutions like colleges, universities, and so on. These have been very positive recommendations from the Ministry of Health to other ministries. Next slide, please. And that's, I think, thank you very much. That's the the final, and wish you all the best.
Thank you so much, Abdikhani. You really did your best to do that quickly, and I do appreciate that. And thank you to everyone for hanging in there with us. We ran a little bit over time, but I really wanted to make sure that everyone had the opportunity to share their work and findings with you. So thanks especially to the presenters today. The world, your lives and the world has changed a lot since you presented these abstracts to the IWAG last year. And it is not nearly as much fun, I know, to rally and present these in front of virtual audiences. But I think this is really a testament to the IWAG and to the global community that we are trying to build, that we believe in learning from one another and sharing our work to improve our impact. And each of you has done your bit to do that today. So it has been my pleasure getting to know you and as new colleagues, and it has left me more optimistic about the future. So thank you so much, and thank you everyone for coming. Have a great week. And if you have questions you want to get to the presenters, I know some shared their emails and some did not, feel free to write me at fedderst@ipas.org if you don't have their email addresses, and I am happy to forward your questions and suggestions onto them. Thanks, everyone. Have a good day.